அங்க வச்சிருக்கியா? இங்க வச்சு பாத்துடலாமா? இது கனெக்ட் ஆகும். ஓகே. என்னம்மா இரு இரு. இந்த வந்துட்டான் ஒரு நிமிஷம். உட்கார் உட்கார். இந்த வந்து பார்ப்போம்.
बोल दो आज ही से, या तो आज मंडे को अभी फोन करके बोल दो, अभी अभी बोल दो कि मंडे हमको 5 बजे तक चाहिए, क्योंकि मंडे हमारे पास, बता दो उनको अभी, तो बहाना हो जाएगा। डार्लिंग अभी बता दो, हम आपको भलाई के लिए बोल रहे हैं, क्योंकि मंडे है ना, मंडे तो हम 5 बजे आएंगे, उसके बाद हम आएंगे नहीं। आप मुझे मौसी आए क्यों नहीं 12 बजे? अच्छा அவங்க
எடுக்கலையே சார், மறந்துட்டாரா? சார்
हम खाली इनको देख
ஒரு பேனா கூட சரி பரவாயில்ல, வேற யாராவது பண்ணிருக்காங்கல்ல, வேற யாருமா இன்வைட், வேற யாருமா இருக்கா? நீங்க இருக்கீங்க. எழுதி மேடம் முக்கம் சார் நான் போட்டிருக்கேன். ஆமா, அன்னைக்கு அஸ்மா 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 பரவாயில்ல, சீக்கிரம் ஒரு பேனை போட்டுக்கிறேன். ஏசி இருக்கா சார்? ஓகே. Asma, you are presenting. Yeah. You come. Okay. Thank you. How do? On பண்ணுடா. வீடியோ ஆடியோ வேற யாருடா இன்வைட்ல? Meeting is about to start in board. சொல்லணும். இதுல போடுங்க. What is that?
Valarmati ma'am. Hello.
சாரங்கன் இந்த சாரங்கன் நம்பர் போடு.
Hello ma'am.
சாரங்கன் நம்பர் எழுது. போன் அடியா இருக்கு. என்ன நம்மளே இதை செய்துக்கலாம். தேங்க்யூ சரண். சாரங்கன் என்ன போடு. 88706. அப்படியே நோட் பண்ணிக்கோடா. அப்படியே போன் அட்ரா, உங்ககிட்ட இருந்தே போன் அட்ரா. 40888. ஏன்னா நான் இதை 88706 40888. Because I'm just posting this message here. My God. City pathology. நம்மளெல்லாம் இது பண்ண சொல்லுதா, அப்பதானே உள்ள வர முடியும். நீ கூட இல்ல என் காதுல வை. City pathology. ஹலோ சாரங்கன், வளர்மதி. என்ன இது பண்ணுப்பா, அப்பதானப்பா நான் பேச முடியும். தேங்க்யூ சோ மச்பா. எப்படியோ சீக்கிரம்ப்பா இது பண்ணுங்க, எங்களை ஹோஸ்ட் ஆக்குங்க, அப்பதான் நாங்க பேசுவோம். ஐ கேன் ஸ்டார்ட் த மீட்டிங். தேங்க்யூப்பா, தேங்க்யூ. மத்தவங்க எல்லாரையும் அந்த அவங்க பேர் என்ன, ஏழ்விழி மேடம், அஸ்மா, அப்புறம் வேற யாருடா? ஏழ்விழி மேடம், அஸ்மா, இந்திரா, டாக்டர் இந்திரா, இந்திரா, அதுக்கப்புறம் வந்து டாக்டர் மேகலா ஃப்ரம் அப்போலோ, அப்புறம் முத்துலக்ஷ்மி என்ன முத்துலக்ஷ்மி இந்திரா ஜாயின் பண்ணிட்டாங்களா? இந்திரா இல்லைன்னா என்னோடதுலயே பேசிடுவாங்க, அதை பத்தி ஒண்ணும் பிரச்சனை இல்ல. முக்குல் அஸ்மா. மேகலா யாருப்பா? மேகலா கிருஷ்ணகுமார் சார் இஸ் பிஸி, பரவாயில்ல. இருக்கிறவங்க மட்டும் பிரசன்ட் பண்ணிட்டோம், ஓகேவா? எல்லாம் அந்த அவங்களெல்லாம் இதுவாக்கிடுங்கப்பா, அப்பதான் அவங்க தம்பி பாப்பா உட்காரு, ஏன் நிக்கிறேன்? ஓகே, தேங்க்யூப்பா, லிட்டில் பிஸி திஸ் டைம், இல்லைன்னா ஃபோன் பண்ணி கேட்கறதுக்கு எனக்கு டைம் இல்லை. ஆமா, இப்படி இருக்கு கடவுளே, சொல்லுடாப்பா. வாட் யூ ஏதுங்கடா, அதான் இன்டர்டிபால் மீட்டிங்கடா. Okay, for the first time we are having less cases, so it's good. We'll finish early. Ma'am, Amy ma'am. Yes. Amy ma'am, phone பண்ணிட்டே இருக்கு. அவங்க கேட்டா first மேடம் பிரசன்ட் பண்ணிடுறேன். Ratan is come. Very good. Jabba first na lama first. ரெண்டு கேஸ் தான். Mute. Hello. Good afternoon to you all. Ma'am, are you online? Can you hear me? Can we start the meeting? Hello? Can you hear me, Dr. Asma? Dr. Emmanuel? He's responding.
Ma'am, am I audible? Asma here. Hello.
My mail is
Hello. Hello. Hello, ma'am, am I audible? Valarmati, ma'am.
அவர்கிட்ட சொல்லிடணும்.
Madam, edit madam.
எஸ்மா என்னோட கரெக்டட் வெர்ஷன் வந்துருச்சா பாத்துக்க.
பேசுறதே உங்களுக்கு கேட்கலடா, கேட்கலப்பா.
கரெக்டட் வெர்ஷன் வந்துருச்சா பாரு.
Asma, can you hear me?
Hello. Yes. I'm able to hear you.
I can. They can hear. Yeah. Try one.
வருதா?
Ma'am, Eril ma'am, I can hear you. I can hear.
Yeah.
Ma'am, Asma here.
Yeah. Welcome, Asma.
Ma'am, this is Dr. Meghla. Can you hear me?
Eril ma'am.
நான் வந்துட்டேம்மா.
Yes, ma'am. Very happy to see you, ma'am. Happy New Year to all of you. So this is the first meeting of
Thank
our,
you. Wish you the same.
2024. Ma'am, thank you, ma'am, and congratulations, ma'am, for your lecture and the award, ma'am. Congratulations.
Thank you so much.
And I'm very
You must
happy
thank
you will be the
the-
first speaker, ma'am.
Yes, yes.
Ma'am, சொல்லுங்க. Ma'am, நீங்க start பண்ணிடுறீங்களா?
ஆரம்பிக்கலாமா
First
என்னோட
case.
ஸ்டோரியா? Yeah,
Correct ஆயிடுச்சு, madam. 2 o'clock ஆயிடுச்சு.
இல்ல என்னோடது வந்து செகண்ட் கரெக்டட் வெர்ஷன் வந்து அதை ஆன் பண்ணிடு. ஸ்கிரீன் பார்க்கலுமே நானு.
Ma'am, give me a minute.
Yeah.
This is just check. Can you able to hear me? Ma'am, can you hear me? This is Dr. Mekhala.
Yes.
Okay.
Mekhala, you're very much audible.
Okay.
You're
Okay.
very
Thank
much
you.
audible. Just give
Thank
me
you,
a
ma'am.
2 minutes. Ma'am's presentation. We're just opening the presentation.
வீடியோ போடக்கூட வேண்டாம். ஆடியோ தெரிஞ்சா போறோம்.
Ma'am, just give me just trying to open it.
யார வணக்கம் பண்ண சொல்லியிருக்கேன். யார வந்துச்சு.
So,
ஓகே.
So welcoming you all to the 37th City Pathology Meet this January 27, 2024, and our first presenter, our Eduluri ma'am. Welcome, ma'am.
Thank you. Thank you. Yeah.
Ma'am, your screen is yours.
Okay. Thank you, Valamati. Thank you, one and all. Good, very good morning and happy Pongal and happy New Year to all of you, the participants and the people available in the meeting. Coming to our case, it's a case of a 74-year-old male presented with for a complete checkup. It was shown 2 sessile polyps in the duodenum. Next slide. Next slide, pa. The images. This is the microscopic picture of the duodenal biopsy material. Next. It's a low power. Are you able to appreciate the duodenal mucosa and the lesion? This is another power, another area where you are able to appreciate the islands of the tumor tissue. Next. There are 7 pictures are there. Any problem? And this is the This is our next high power view of the one of the areas where the gastric mucosa with some of the crypts are showing some rod-like structures and the lymphocytes in the subepithelium, and then the tumor cells which are round to oval with dark staining nuclei and an indistinct nucleoli arranged in a small, larger lobule. Next. Yeah, this is a high power where there are areas of some cribriform pattern was there. The nuclei were visible and nucleoli were visible in this area. Even this area was surrounded by small mature lymphocytes. Slide.
Ma'am, yes, ma'am.
Next slide. Sorry, bothering you.
Space கம்மி வாங்கிட்ட போன் வாங்கி ஸ்பெண்ட் பண்ணேன் யூசுவலா.
Okay, space receipt பண்ண தெரியும்.
ஃபர்ஸ்ட் சார்
ஆமா, ஒரு batch dispatch பண்ணிட்டாங்க. இது போயிட்டு நான் பின்னாடி வரேன்.
இருக்கா?
இந்த train நமக்கு இருக்கா நான் உங்களுக்கு
The others, please mute yourself, please. Ma'am, நீங்க continue பண்ணுங்க.
Yeah. Next slide. This is another area to appreciate the lymphocytes cuffing the tumor areas. Next slide. Next. Yeah. This is also the same one. Next one. This case we have reported as, if anybody want to say anything in the floor, they could have said something.
Ma'am, we thought it could just a
Think not
neuroendocrine tumor.
Yeah, but why that small lymphocytes are so densely populated around the tumor lobule? So with the H. pylori, and there are areas of gastric metaplastic focus was there. So I thought it could be a synchronous maltoma. I never referred the literature for a maltoma, but I thought why not we have a synchronous tumor of low-grade type with the neuroendocrine tumor. So, but we asked for a IHC marker. The smaller polyp also showed a similar picture, but there was more of neuroendocrine tumor islands were there with less of lymphocytes. Next slide. Next slide. Next slide, ma. Yeah. Is it able to view everyone? Yeah. No. The previous one. IHC report.
The IHC report.
Send the
Yes, ma'am.
IHC.
Yes, ma'am. The IHC report is there.
Yeah, this is the endoscopic biopsy of the duodenum first part, and then the markers were showing LCA positive, synoptophysin and chromogranin for strong positivity, and Ki67 15 to 20%, and in the lymphoid cells, 8 to 10% in the neuroendocrine cells. And CD3 negative and focal positive in mature lymphocytes, CD20 positive and highlight the follicular pattern, and CD138 just to rule out the other types negative, ECL2 positive, and CD10 positive. So the report came as consistent with moderately differentiated neuroendocrine tumor, WHO grade 2, and follicular lymphoma grade 2. Next slide.
Charmi.
Yeah. So this because of the rarity of the presentation of neuroendocrine tumor of the GI tract with second primary synchronous tumor. And if you all know that NEN is upcoming tumor in most of our cases, and it is very common in most of the epithelial organs of the body and not rare in GIT, whereas NEN and GIT with other secondary primary is an exotic event. And considering the study group of material, the mean age of the patient was found to be 60.2 and common in male and presented with metastatic potential in some of the cases and presenting like a polyp, which is a classical presentation seen in our case. Next slide. Yeah, that is coming to discussion. This 95.4% were neuroendocrine tumors, out of which 80% of second primary malignancy in GIT, common in stomach, large intestine, small intestine, and esophagus. The percentage more common in the stomach. Then second most common type of second primary malignancies, it can be an associated adenocarcinoma along with a neuroendocrine tumor or other adenocarcinoma of the other segment. And GIST has been seen as a second common primary tumor. Other men in neuroendocrine tumor in different GIT segment is 7.9%. Lymphomas are 6.8%. It's the rarest of rare. Next slide. Yeah. So when you assess the references from the various reports, the association of adenocarcinoma with neuroendocrine tumor in GIT, the p-value is less than 0.001, whereas adenocarcinoma in the same segment of GIT, p-value is 0.001. So, how rare it is, we can see. And one more, the pathophysiology ability of neuroendocrine tumor to generate synchronous tumor by autocrine and paracrine effect. And NEN with metachronous tumor of the lung, prostate, kidney, colon, thyroid at a higher rate than general population. That is from study. And considering the second primary malignancy with CA prostate 34.9%, lung 24.9%.
Ma'am, ma'am, continue, ma'am.
My video is gone. Presentation.
It's okay, ma'am. It's okay, ma'am. You can continue with your audio. We are able to hear you. Just now you.
Okay. Most other NEN I've told you, and then the prostate, lung, CA, stomach, esophagus is 4.9%. That is called as the SIR, that is incidence rate of tumors. And the just to highlighting the type of lymphoma what we are seeing in our group, this belongs to an indolent group, that is follicular lymphoma, marginal zone T-cell lymphoma, and CLL and SLL and mycosis. Whereas the aggressive type belong to diffuse large B-cell lymphoma, Burkitt's, mantle cell, and precursor T-cell, and B lymphoblastic lymphoma. Coming to summarize the issues, that is the discussion part of it. The rate of second primary is increasing over the last decades due to new therapies, early diagnostic markers, screening tests. The prevalence of SPM is increasing, and primary GI follicular lymphomas are very rare and incidental. Usually, it be presented by during endoscopy and rarely present with abdominal pain and dyspepsia. Whereas duodenum, the most common site of occurrence, and multifocal presentation do occur. And prognosis is very good and complete remission. Very rarely they may go in for a high-grade lymphoma. more attention to be invested in the prevention and therapy of second primary malignancy. This case is presented for the occurrence of the neuroendocrine tumor along with follicular lymphoma grade 2 in the duodenum, presenting as a clinical polyp as a clinical picture in association with other reports. So just to highlight how much we have been exposed to the second primary tumor in the along with neuroendocrine tumor in the duodenum. Thank you. Anybody have any difference of opinion? I'm not able to visualize, ma. Hello.
Ma'am, yes, ma'am, can you hear me?
Yeah, I can hear you. I'm not able to visualize anything. Okay.
Ma'am, that was a very rare case. Actually, what's the prognosis, ma'am?
இன்னும் வரல மேம். டிஸ்பேட்ச் மட்டும் பண்ண சொன்னாங்க.
Ma'am, yes, ma'am.
பண்ணி வைக்கிறேன்.
Ma'am, can you hear me?
I think Madam's audio is also gone. She has to log in again, I
Oh,
think.
madam. Chandra, madam, welcome. She was
Good afternoon, madam.
talking
Good
about neuroendocrine and lymphoma
Yes,
present.
yes, I was listening only. Yeah, very rare case indeed. And of course, the advances in follicular lymphoma, the current WHO, 2022 hematolymphoid also has changed the terminology in follicular lymphomas. It is not called follicular lymphomas at all. So that
Diffuse.
also, ma'am is back again.
Yeah. No, the problem is here the report, ISC report came as a follicular lymphoma grade 2. And neuroendocrine also grade 2, they have marked it.
Yes, ma'am. Yes.
And
okay.
I was stunned with the first time when I saw the slide. I just then circulated to few people. They have never agreed the lymphocyte component to give any importance. But I was little hesitant to give a very benign report about the presence of lymphocytic infiltration is so much there. So we cannot take off any report in from my mind. I thought it could be a montoma, so I just presented like the initial report. But then we asked for a IHC. What do you say, Chandra?
Yes, ma'am. I agree. I think because of your extensive work on H. pylori and the induction of malignancies secondary to H. pylori, you have really been able to pick this case up. So
Yeah.
suspicion, high index of suspicion, especially when there is one tumor at one area, we generally tend to think that we have made the diagnosis and we tend to push the slide off. So instead of that, yeah, that is the tendency which, involuntary creeps into many of our minds. But in spite of all those things, like you have concentrated on the lymphoid aggregates and you have proven that it is a follicular lymphoma, which is a very good thing, ma'am, and it is a very, very rare case as well.
Yeah, that is why I just wanted to share
You
with
please
you all.
mute your voices. Can everyone else please?
Can anybody else had a similar experience or a different one? Because they said from the literature, adenocarcinomas from other areas can be seen. So like that presentation can be variable presentation. So just to highlight the occurrence of two tumors in the same patient, that too it's a very classical, like a textbook presentation in our case. And that person also refusing to take any treatment. He said, more than 5 years I'm having this. I'm quite comfortable. I don't want to go to take treatment.
So he hasn't had any therapy at all, ma'am?
No.
And how is he now?
Yeah, now he's supposed to take since the lymphoma we have given the treatment, we can given the diagnosis, he should be willing forward. But considering his age or no symptoms, he didn't want to undergo any therapy. But I've been following it up.
Were there any
As for-
lymphoepithelial lesions, ma'am, there in the mucosa?
Huh?
Ma'am, were
Yes,
there any
ma'am?
lymphoepithelial lesions there?
In this slide, illa.
And when maybe in the நீங்க பார்த்த slides-ல lymphoepithelial lesion இருந்துச்சா, ma'am?
Illa. It was the epithelium was quite frequent and I mean quite normal, and only the lymphoid aggregates, it was quite mature lymphocytes in the near the epithelium, whereas only the deeper lobules are surrounded by little aggressive or quite variable sized lymphocytes were seen.
And generally, lymphoepithelial lesions are seen in marginal zone lymphoma, which is a maltoma. But this one has been reported as follicular lymphoma. So I
Yes.
don't know how many cases of follicular lymphoma in the gastrointestinal tract are showing lymphoepithelial lesions. That we have to, I think, look into also.
Okay, ma'am. Thank you, ma'am. Thank you, ma'am, for the wonderful case.
Yeah.
And
But
hats off to your enthusiasm.
I just wanted to share this entity because how common and how many of you would have seen long back. So I thought before publishing this as a case report, I thought we'll get feedback from our faculty. Thank you so much.
Any of the participants have anything to share?
Anybody?
If not, we can go on to the next case. If anybody has anything to share, or we can go on to the next case.
Yeah. Thank you for the patient here.
Thank you, ma'am. Thank you for the nice case, and thank you so much, ma'am. And next presenter will be Dr. Emmanuel from Miyot Hospital.
Good afternoon, ma'am. Am I audible, ma'am?
Yeah, you're audible. You can share your screen.
Thank you.
Now the Zoom report.
Is my screen visible, ma'am?
Yeah, your screen is visible. You can start.
Yeah. Good afternoon. I'd like to present a case of a 38-year-old male from Seychelles in Africa who had been previously diagnosed with acute lymphoblastic leukemia elsewhere, and he had come here with limited response to therapy and was referred here for further treatment. Patient gave past history of congenital heart disease and was otherwise asymptomatic. Clinical examination, only mild hepatomegaly was there with no other symptoms or any other clinical findings, and routine baseline investigations were done. Coming to the CBC graph showed leukocytosis, which was marked with lymphocyte, which was markedly elevated with lymphocyte predominance. The graph showed a gray zone in the lymphocyte and blast area with an eosinophilia and monocytosis. Was also noted. RBCs were microcytic hyperchromic on smear, and the lymphocytes, they were medium to large sized, atypical. They were showing multiple lobulations, as you can see on the images in front of your screen. Some were having multi-lobulations and with condensed chromatin, absent nucleoli, and scant cytoplasm. So with this morphology, initially we had, because of the previous treatment that he had received, we were still in between whether it was a leukemic presentation based on the cell counts, or whether it was a chronic lymphoproliferative disorder, whether it was immature or the mature variant. So we went ahead and did the flow cytometry. Coming to the flow cytometry, here you can see that the cells are gated, lymphocytes are gated at 70% at the site scattered CD45 graph. There were no blasts on the smear as evidence below, CD34 being completely negative. The lymphocytes that were then gated were CD4 positive and CD8 negative. As you can see in front of your screen, the CD4 positive was biphenotypic with 60% showing positivity and 30% being negative. CD8 was negative, CD7 was negative, CD5 was positive. All other markers for myeloid and NK cell origin were all negative, and B cell origin was also negative. These images for sure CD20, 19, and CD22 markers as well. Coming to the marker at the bottom of the screen, coming to the TDT, which was dim to negative. The problem with the TDT was that because of the prior treatment that he had taken, usually the TDT markers tend to very little chance to like migrate. So in that reason, we were a little confused whether we were still dealing with a leukemia or a CLPD. But being the CD34 that was negative, and we also had another marker to help us out as well. So we also we had referred literature which showed us that mature T cell lymphomas lack immature antigens like 34, TDT, and CD1A, and typically show dimmer CD7 expression instead of the bright CD7 that was seen in the TALLs or the LBLs. So based on the morphology and the flow cytometry and our above findings, we had a high suspicion for a mature T cell lymphoma, and leukemia was raised. The other confounder that was very significant for the patient was that though he had only presented with generalized weakness initially, the platelet counts were completely normal. The peripheral blood picture, even though we were like trying to suspect the TPLL or maybe even something that we are missing, we weren't able to like find out because the chemotherapy that was already previously given. Complete absence of other clinical features are also significant confounders in this patient. So initially, after our diagnosis, we waited for some time, and then we went ahead with a strong suspicion that it could be HTLV associated, given the origin and the country that he is from. So we went ahead and did a CD25. CD25 came back as positive. We also went ahead and did serology for this patient, which also ended up coming out to be positive at 20.49. A final diagnosis of HTLV-associated adult T-cell lymphoma leukemia was given for this patient. Patient was started on intensive chemotherapy initially, given that his presentation that he had no symptoms at the start, except for some mild hepatomegaly. But initially, even though we started intensive chemotherapy, the patient did not. There's no chemotherapy exactly for this current disease that we're talking about. So he was started on a hyper CVAD regimen, and he did not respond to it, and he developed lymphadenopathy, and he developed significant supraclavicular lymphadenopathy. Coming to the lymph node architecture was diffusely effaced. You can see the lymphocytes that the cells are very pleomorphic. They are large, the medium to large sized, and you can see some atypical mitosis on your screen as well. Coming to the IHC markers that were done, now to confirm, we did CD3, CD4, which turned out to be strongly positive. CD7 was negative. CD28 and 34 were all negative. IHC markers for ALK, CD30, and TDT to rule out ALK and CD30, of course, for anaplastic large cell lymphoma, and the KCC7 labeling index was at 70%. So overall, in this picture, this confirmed a diagnosis of adult T-cell leukemia by lymphoma in this patient. Coming to the discussion for this topic, the adult T-cell lymphoma is usually associated with the HTLV1 virus. It's most common in the tropical areas. It is a retrovirus and affects 10 to 20 million people. Most are asymptomatic. They acquire the disease very early in life. And around the age of 20 to 30, they usually develop this disease. Most of the percent, 95% are asymptomatic, while HTLV1 associated myelopathy and tropical spastic paraparesis usually occur when this virus infiltrates into the spinal cord. Some patients, unlucky enough, are in progress to adult T-cell lymphoma. It's very clinical disease, male is to female, 1.5:1, usually occurs from the 3rd to 9th decade. So the essential diagnostic criteria for this would be a neoplastic lymphoid cell proliferation with mature T-cell phenotype, which occurs in the HTLV1 carrier. A desirable one would be a lymphoid cell with prominent convolution and ovulation, identification of monoclonal integration of HTLV1, which was done for this patient as well. So coming to the grading of this is a Shimoyama classification. Acute and lymphomatous, usually very bad prognosis. By less than 1 year, they usually do not progress beyond that. Chronic and smoldering, they have a 45% risk of progressing onto an acute or lymphomatous variant. Primary cutaneous tumoral type usually presents with numerous skin lesions for the patient as well. Thank you.
So very nice case, Emmanuel.
Thank you, ma'am.
Hi, I'm Dr. Chandra. Yeah. So
Good afternoon, ma'am. Good afternoon, ma'am.
Good afternoon. So the suspicion that it could be HTLV associated lymphoma came because of the negativity of the immaturity markers, is it? Is
Ma'am,
that so?
it was the morphology that was predominantly very striking, ma'am. The morphology, we did not see any blast. We were not seeing exactly flower-like cells. We were seeing multiple lobulations, and the positivity for the T cell markers, both all put together, that's what raised the suspicion, ma'am.
Okay. Very nice presentation. Yeah, tell me.
So we were thinking that are we missing out on something because the prior chemotherapy that was given has something changed in the patient, the time duration. We were not sure based on his history, so we went ahead and we did the flow cytometry and this confirmation as well, and we came back positive.
Yes. So with the flow only, I was having that doubt. TDT and all other immaturity markers you said were negative. But
Yes,
in morphology, you could see that the cells were not normal and they were showing some abnormal, like pathological
Yes,
features.
ma'am.
So
Yes,
put together, like conjunction of the morphology and the flow cytometry results, I think probably you did
Yes,
go
ma'am.
for other markers, additional markers like CD25.
25. Yes, ma'am. Yes, ma'am.
Yes. So is that the inference you want to give us all? Is what I was trying to ask.
Yes, ma'am. So like it is not in separate. We can't do anything separately. It needs the integration of all three together to finally come to a great clinical picture and start treatment for this patient. Ma'am.
Wonderful. And IHC, did you get a positivity for any specific marker on immunohistochemistry for this case?
Ma'am, we actually the patient was already having a diagnosis, ma'am, and we didn't do any specific marker as such. We just confirmed what was already done on flow cytometry, and we ruled out negative diagnosis like anaplastic large cell and AITL.
Yes, yes. Thank you so much.
Thank you.
Ma'am, I have a question if I can interrupt. Hello?
Yes, ma'am.
Emmanuel?
Yes, ma'am. I'm there, ma'am.
Dr. Asma here. Just a query. Can you tell me from where the patient was? Because adult T-cell leukemia lymphoma are usually endemic to Japan and the Caribbean region. As per the WHO, I mean, they don't come regularly. So it's a rare case. And I would like to know from where the patient was actually.
Ma'am, he's from Seychelles he's from Seychelles in Africa, ma'am.
Okay, sure. Okay, thank you.
Yeah, but there was also a previous patient here who did have HTLV1 with ATLL, ma'am, Indian origin. There was a patient admitted here.
Okay, sure. Thank you.
Thank you.
What was his peripheral smear, Dr.
Ma'am, peripheral smear, I will just show you the image, ma'am.
He showed the image. Blast.
Ma'am, is it visible, ma'am?
Yeah.
Yeah, the lobulation also.
Okay, Dr. Iman. Okay. Is bone marrow were all done? Was it done?
No, ma'am. We didn't proceed the bone marrow, ma'am. We went straight to the flow cytometry, ma'am, because the cellularity in the smear.
Okay. Thank you, Dr. Emmanuel. That was a nice case. Thank you.
Thank you.
Dr. Valamati, this is Dr. Deepthi.
Yeah,
Hi.
Hi.
Yeah, one more thing I just want to add in this. So actually, this patient had CD7, which was negative in the flow. So usually it comes bright in your acute lymphoblastic leukemia. So that is another reason. But because the patient was on treatment continuously, so we had it should not be decreased because of the treatment related changes. But that is the one suspicion which has given that why that CD7 is coming on the lower side, negative expression. So that is helps in think whether we should go for more markers.
Ma'am, one more question. Any cutaneous lesions in this patient? Because
no, the patient is not having any
diagnosis.
No, there is no skin lesions until now. Even in the relapsed patient has come with lymph node, but there is no skin lesion still.
But conclusion-wise, HTLV serology has given us the correct diagnosis.
Yeah.
I mean to say the differential diagnosis definitely cutaneous T-cell lymphoma or cesaria also will be one of the DDs here.
Oh, okay.
CD4 positive, 8 negative. Yeah, CD7 negative. Thank you.
Yeah. Thank you, Asma.
Was there any history of drug abuse? Because this HTLV infection with drug abusers, it is more
common.
No, we have not. They have not nothing like that. No history of drug abuse.
38-year-old when the age group also.
Or either means for us it was not given any drug abuse history.
Okay. Thank you.
Yeah. Thank you.
Thank you, Dr. Emmanuel. That was a nice presentation. So we'll go on to the next case, Dr. Indra Priyadarshini.
Yes, SMC.
Everyone. First of all, I would like to thank my professors, Dr. Sumitra ma'am and Dr. Valarmati ma'am, for giving me an opportunity to present in this forum. Moving on to the case details, 17-year-old female who was married and alipharis, with complaints in the left perianal region, along with pain for the past 2 months duration. She had history in difficulty with passing stools. There was no history of dysmenorrhea and dyspareunia. On clinical examination, She presented with a diffuse swelling in the left perianal region, which was extending from the inferior aspect of left labia majora up to the anal verge. And she was subsequently proceeded with radiological investigations. On ultrasound with CT screening, it showed an ill-defined heteroechoic lesion measuring 3x7 centimeters with internal cystic components and internal vascularity noted in the perineal region, extending up to the left ischioanal and the left ischiorectal fossa, causing a mass effect over the rectum, and an impression of query-aggressive angiomyxoma was given. Further, MRI plane study was done, which showed a well-defined lobulated, a mixed-intensity lesion, which was measuring about a 7 into 3.8 into 11 centimeters in the left perianal region, extending from the 12 o'clock to 6 o'clock position, involving both the left ischioanal and the ischiorectal fossa. On contrast study also, a similar heterointense lesion was noted, and the lesion was not seen invading into the anal canal or the rectum or into the perianal skin. The impression of aggressive angiomyxoma was given, and further the patient was proceeded with a wide local excision. The mass was resected and it was oriented with sutures and sent to our department. Macroscopically, we received this wide local excision specimen as a grey tan lobulated mass with fatty areas measuring about 9 into 8 into 5 centimeters. On cut surface, we show it shows a grey tan grey white area with focal areas of hemorrhage infiltrating into the adjacent fatty areas. One of the resected margin, which is the medial resected margin, was grossly involved by the tumor, and representative bits were taken both from the tumor and the resected margins. So microscopically, under the scanner view, we are able to see a cellular spindle cell neoplasm with focal areas of hemorrhage. Under the low power view, we are able to see the spindle shaped cells arranged as short vesicles and a vague storiform pattern. Under the high power view, we are able to see a uniform population of gland spindle cells with an ovoid to elongated vesicular nucleus with inconspicuous nucleoli and a pale eosinophilic cytoplasm, which was admixed with inflammatory cells composed of lymphocytes, few plasma cells, mast cells, in a background of myxoid to a collagenous background. And this picture also shows few congested blood vessels with perivascular collection of inflammatory cell infiltrates. The mitotic rate was also very minimal. It was only 1/10 high power field. This image shows the infiltration of the neoplastic cells into the adjacent skeletal muscles and the adipose tissue. So with this morphology of a low-grade spindle cell neoplasm, we further proceeded with the immunohistochemistry. So the ALK showed a diffuse cytoplasmic positivity in 80% of the tumor cells. Then Desmin and SMA showed focal positivity. Ka67 showed a positivity of 10 to 20% in the tumor cells. The other negative markers were S100 and myogenin, ruling out the tumors of nerve sheath and skeletal muscle differentiation. So with this histomorphology and immunohistochemistry, the diagnosis of inflammatory myofibroblastic tumor in the left perianal region was signed out. So before leading on to this diagnosis, so other conditions with a similar morphology are to be thought of. So one such condition is nodular fasciitis, which is composed of plump myofibroblastic cells with a tissue culture-like architecture, but it lacks this inflammatory cell infiltrate, and the history also helps in delineating this condition. So it is usually SMA positive but ALK negative. Then the fibromatosis, desmoid fibromatosis is another condition with similar morphology, composed of long sweeping fascicles of spindle-shaped cells having infiltrative borders. And apart from the positivity of SMA and Desmin, it shows an aberrant nuclear reactivity for the beta-catenin. So the next condition is leiomyoma, which is a benign tumor arising in the deep soft tissues and the viscera, composed of an organized fascicular pattern of uniform spindle-shaped smooth muscle cells, showing positivity for SMA and Desmin, and negative for ALK. In inflammatory leiomyosarcoma, this condition also occurs in the younger children, but it's composed of atypical spindle-shaped cells with cigar-shaped nucleus and more of lymphoid infiltrate, showing positivity for SMA, Desmin, and variable positivity for CD117. And this GIST and inflammatory fibroid polyp comes as a differential when this IMP presents in the region of GIT and in the mesentery and omentum. So GIST usually shows a diffuse positivity for the CD117 and variable positivity for CD34 and SMA. Then inflammatory fibroid polyp usually presents as a submucosal mass, which is composed of reactive myofibroblast proliferation along with inflammatory cells predominantly composed of eosinophils, showing positivity for CD34 and SMA. So when there is predominance of plasma cells, we also need to consider this IgG4 related sclerosing disease. It is actually a benign fibroinflammatory condition with unifactive lesions composed of dense lymphoplasmacytic infiltrates with IgG4 positive plasma cells, storiform fibrosis, obliterative phlebitis, and variable number of eosinophils. So the serum levels of IgG4 is also to be checked. And the next condition is rhabdomyosarcoma, occurring in the young age, predominantly presenting as irregular vesicles of ovoid to spindle-shaped cells with focal rhabdomyoblast formation, showing positivity for desmin and myogenin. Then schwannoma, especially the cellular schwannoma, comes as a differential. It's a sharply demarcated spindle cell tumor surrounded by lymphoid cuff, showing positivity for S100. So in all of these conditions, the ALK is negative, which very well rules out and clears our diagnosis. So coming on to the discussion part, it's the neoplasm which is categorized under the myofibroblastic tumors of soft tissue of intermediate category, which is rarely metastasizing. Most common locations being the viscera and the soft tissue of young children and adults. And etiology is unknown, probably attributed to the autoimmune conditions, trauma, or chronic infections. Pathogenesis is related to the ALK genomic rearrangements in most of the cases. The ROS1 NTRK gene rearrangements in 5 to 10% of the cases. All these genes encode for the receptor tyrosine kinase. So these all patients lead on to the oncogenic activation of the receptors. This condition presents has 3 histological patterns. The first one is the myxoid or the vascular pattern, which is predominantly composed of myxoid areas with the plump spindle-shaped cells and a prominent vasculature. The second pattern is a proliferating compact spindle cell pattern, which is similar to our case, which is composed of cellular myofibroblast proliferation along with inflammatory cell infiltrates. And the third one is the hypocellular fibromatosis-like pattern, which is hypocellular, composed of scattered, elongated spindle cells with scattered lymphocytes and plasma cells. And the recurrence rate is quite high for the extrapulmonary lesions occurring in the abdominopelvic region, in the uterus and the bladder. And distant metastasis also very minimal, it is less than 5%. And this case was mainly selected because of the rarity of the location. So no such case has been reported in the perianal region in the literature. And this is the first case to our knowledge which is being reported in our institution. And coming on to the management options, it includes the complete surgical resection with adequate negative margins. In our case, since one of the margin was involved, and since the tumor was abutting the rectal wall, it was advised revision surgery, but the patient denied it and is presently under follow-up. So these are certain targeted therapies using ALK inhibitors like crizotinib, alectinib, which has shown efficacy in producing a favorable outcome. So thank you.
Can we just see the histopathology once again, Ma?
Yes,
It's
ma'am.
like the very little cellular. Low power. Was the vascularity, how it was?
It had only focal areas of hemorrhage.
You never thought of solitary fibrous tumor?
No, ma'am, it didn't have such kind of a vasculature in this one.
That can be common in the perineum or perianal valval region also. Usually. Okay.
STAT5, SFT வந்து ALK positive இருக்குமா madam? I thought it ALK will not be.
நானும் அது பார்க்கிறேன் நான். But pattern பார்த்தா அவ்வளவு vascularity தெரியல ஆனா
that was one of the differential diagnosis considered, madam.
Yeah. We cannot exclude SFT in any of these spindle cell tumor with vascularity. Always we should have
ma'am.
it in mind.
Yes, ma'am.
Nice presentation.
Yes, ma'am. Any other inputs from the other participants? Okay, ma'am. Solitary fibrous tumor will also be considered in the differential diagnosis. Thank you, ma'am. Thank you, Erin, ma'am, and thank you, Chaitra.
SAT6 was done, no, in this case?
STAT6 was not done, madam. STAT6 was not done. Since the morphology more, it didn't look like SFT, so STAT6 was not done. Okay, then we will read and we'll take the block back and try doing STAT6, ma'am. She's just a 19-year-old female, around the ages. Okay, ma'am. Thank you, ma'am. Thank you. We go on to the presenter, Dr. Mekhala. Dr. Mekhala, you can share your screen.
Ma'am. Yeah, ma'am. Yeah. Can you see, ma'am? Hello?
Yes, Dr. Mekhala.
You can see the screen, right?
Yeah, you can see your screen and you're audible. Yeah, you
okay. Okay. Good afternoon to one and all. So I'll start with my case. This is a 67-year-old lady who presented to the OPD with complaints of burning micturition and lower abdominal pain since 10 days. She's a known case of diabetes and hypertension. On clinical examination, there were no significant findings, just some tenderness in the lower abdomen. Her urine routine was normal. Urine culture showed Enterococcus fecalis. Then they proceeded with an ultrasound abdomen, which showed an asymmetrical bladder wall thickening along the anterosuperior aspect, crossing the serosa with extension into the adjacent soft tissue. So the ultrasound concluded a neoplastic etiology in the bladder. This was followed by a CT scan, which also showed an asymmetric heterogeneous enhancing solid mass-like thickening of the anterior wall of bladder with areas of necrosis with marked perivesical fat straddling. So possibility of a neoplastic etiology. So the clinical diagnosis and workup they decided to do as a carcinoma urinary bladder. So they planned for a cystoscopy and biopsy and did a PET CT, both done simultaneously. So the PET CT showed hypermetabolic, heterogeneously enhancing mass-like wall thickening with necrosis involving the anterior wall of the bladder, suspicious of a primary urinary bladder malignancy. There were no significant metabolically active pelvic nodes, no other significant metabolically active disease elsewhere in the visualized whole body survey. So we received the biopsy of this patient. We received multiple irregular gray white tissue bits, altogether aggregating to 1 cc. The entire tissue was processed. So now let's look at the histopathology. So this is a low power view. Most of the bladder chips did not have any mucosal lining. There was just one fragment which showed urothelium, which looked normal. Now this is the stroma of the bladder showing sheets of mononuclear cells and congested blood vessels in between. Another low power view. Some areas show some vague nested pattern, but rest of it, as is through and through, sheets of mononuclear cells in the low power and the scanner. Now let's look at these cells on a higher magnification. Yeah, so these are again monomorphic cells around intermediate to large size. They have a vesicular nuclei, open chromatin, small nucleoli. Some binucleate forms were seen. Some cells had eccentrically placed nuclei, like a plasmacytoid morphology. This was the majority of the tumor looked like this. Some areas, there was some crush artifact with cells having a spindly to ovoid nuclei and moderate amount of cytoplasm. All the cells had moderate amount of cytoplasm. So based on these findings of seeing sheets of monomorphic cells with the kind of many cells having eccentrically placed nuclei, we gave the impression of a neoplasm with plasmacytoid features, and we gave these as a differential diagnosis. There is a rare variant of urothelial carcinoma called plasmacytoid urothelial carcinoma. So given the history and all the radiology findings, we gave this as the first DD, plasmacytoid urothelial carcinoma. And the second DD, we said hematopoietic neoplasm to rule out a plasma cell neoplasm. And we asked for IHC, and these are the IHC findings. So first we started with the cytokeratin. We started with cytokeratins, CK, CK7, CK20. All three were negative, not even a single cell. It was only the lining epithelium took the CK positivity, but all the neoplastic cells were negative for cytokeratin. So that was the first DD of urothelial carcinoma getting excluded with this. So next we added the plasma cell markers, CD138, CD38, MUM1. All the plasma cell markers were also negative. Then we put in GATA3, which is positive for primary bladder carcinomas because that was working. GATA3 also came negative. So now we were like, what next? We have ruled out carcinoma bladder and we have ruled out plasma cell neoplasm. So we decided let's go to other hematopoietic lineages. Again, it was negative. LCA was negative, CD3 negative for T cell lineage, CD20 negative, B cell lineage. So proliferation index was around 20 to 25%. So again, we thought, could it be a sarcoma which had an epithelioid morphology, or could it be an extrarenal rhabdoid tumor? These were the two things. So for that, Vimentin again was patchy. It was not diffusely positive. Few cells were positive and many cells were negative as well. And we did INI1. So extrarenal rhabdoid tumor will have negative INI1 loss, but this tumor had retained INI1. So again, we were stuck. But somewhere, so thinking of any three lineages of carcinoma, sarcoma, or hematopoietic, our gut feeling was this is going to come like a hematopoietic neoplasm only. So we decided let's add some more mature markers for B and T cell lineage, and let's add some primitive markers as well. So mature B and T cell CD79A, we added for another B marker negative and T marker CD2 negative. Now the primitive marker CD43, which can come in both mature and CD43 can come in mature T cell lymphomas as well as primitive tumors. So CD43 came diffusely positive in this case. And then we had CD4 in the T cell marker, CD2, 5 were negative, CD8 was negative, but CD4 came diffuse positive. So then we decided let's add some more. So with the positivity for CD43, we decided let's add the marker. That's when we thought maybe this is the diagnosis. We had a diagnosis in mind with this, and we decided to add markers keeping that diagnosis. So we added c-KIT, diffuse and strong, CD68, diffuse and strong, CD99, diffuse and strong, MPO. So would anyone like to give a diagnosis?
Is it a myeloid sarcoma?
Yeah, ma'am. Yes. So it was a myeloid sarcoma, which is what we had not expected it at all, both on morphology and clinically, because the patient presented with a single, the only lesion she had was a bladder mass. And we went back to the history. There is no history of leukemia or any hematological condition in the past. But given and even a full body PET CT revealed only a prominent bladder mass, and which was not there in a differential diagnosis. Even on IHC, after everything turned negative, we finally, after adding the primitive markers, we got this diagnosis. So just a few words. So myeloid sarcoma is a tumor mass of myeloblasts or immature myeloid cells occurring in extramedullary sites or in the bone. So the most common sites are skull, paranasal sinuses, sternums, ribs, lymph nodes, and skin. So now the myeloid sarcoma can occur de novo. They can occur or concurrently with AML or myeloproliferative disorder. So the diagnosis can be missed in about 50% of cases when immunohistochemistry is not used. So like about 25% can occur in the absence of any other evidence of AML or predated by months or even years. So this patient is probably comes under this category. sorry, about 35% of adults, it presents simultaneously with AML or MDS, and about 40%, they have a prior history of leukemia. So this myeloid sarcoma can be of two types, mature or immature type. So the mature type is probably more easy to diagnose histopathologically because they will be admixed with mature neutrophils, eosinophils, like as seen in this case, the myeloid precursor cells seen admixed with eosinophils and neutrophils. This kind of picture was not there in our case, where it was primitive, only predominantly showing primitive cells. We did not see any mature myeloid cells. So this is a blastic variant, which is probably what our case was, where uniform round cells with enlarged nuclei, prominent nucleoli, some centrally placed, some eccentrically placed, and with irregular nuclear contours. So IHC wise, based on the kind of differentiation of the myeloid sarcoma, it can be CD68 positive. There are two clones, KP1 and PGM1, both can come. MPO, c-KIT, CD99, and lysozyme. Some other helpful markers are CD34, TDT, CD56, 30, glycophorin 4. Then sometimes myeloid sarcomas can express T cell markers as well, like CD43 and 4, which was expressed in our case. So just the take-home message from me, always morphology, whenever you see sheets of mononuclear cells, never rule out a hematopoietic neoplasm. And even if your mature markers like LCA 3 or 20 are negative and you still have a suspicion of hematopoietic neoplasm, always think of primitive tumors. So this case being a myeloid sarcoma. So once we added the primitive markers, we could get our diagnosis. Thank you.
Doctor, you could have posted the slide little earlier. So everyone would have had a chance to
a
DD. This is what we expected. Because on the floor, we won't be able to discuss.
Yes, ma'am. Yes.
I feel all the presenters try and put it at least 2 or 3 days earlier than during the presentation. It will be useful for everybody to work up.
Sure.
At first, I thought it could be a round cell, the small cell neuroendocrine I was thinking. But the pattern what you have given.
Yeah. They were not looking small, but this actually quite large.
It is more going for a
anyway, CK was negative. And now this patient is being treated with imatinib, given the c-KIT. She's received 2 cycles of imatinib therapy. And she's responding. And peripheral smear is normal. They have not yet done a bone marrow. So right now they're treating it as a primary sarcoma only without associated leukemia or myeloproliferative disorder.
So a large panel to be done in a basic.
Yeah. So this can be when you're stuck with initial. So we just started with CK, imatinib was one of each. Once everything was negative, we added the primitive markers. So
very.
What were the primitive markers which you used? Because there is
we did TDT also. We start CD99, ma'am. Yeah, 1 second. CD99. CD99 came positive. Then later c-KIT. This we added later, ma'am. First round we added CD99, CD43, and TDT.
CD99 and c-KIT. c-KIT, of course, Marcel was probably one of your differential diagnosis. But CD99, why was it actually added?
No, just for the primitive, ma'am. We added it as a primitive marker, CD99 and this one. TDT also we did. It came negative. Then CD68.
And even Ackerman described. Yeah. Okay. And in Ackerman also, no, like there is a sentence saying that if pancytokeratin LCA CD23 are negative, no, go for markers like plasmacytoid. Like it could be a plasmacytoid lymphoma. So do CD138 or even an image for plasmacytoma. And then do a CD30 also because it could be a Hodgkin's, like which
is ma'am. Yes, a CD30 some few cells came up, but not enough. Few cells. Yeah.
No, I'm just wanting to add one more point to your already exhaustive pathological presentation.
Yes,
that's
all.
So case 68 also, CD68 is positive.
Yes, ma'am.
68, 34 and CD117 all favoring the diagnosis of
myeloid sarcoma.
And one more point, like for the first case, no, like ma'am, follicular lymphoma, I was trying to tell you. that there is a change in the current WHO 2022 classification of follicular lymphomas. Currently, there is no grading which is recommended by the WHO, but ICC still says you can grade the follicular lymphoma, and then it is called a classical Hodgkin's classical follicular lymphoma. Classical follicular lymphoma it is called, and there is no grading by the WHO currently. So this one.
And first bit endometrium with the serosa verdict when it's not clean properly. So
Thank you, doctor.
Hello, I'm Dr.
Thank you, Dr.
Parthiban here.
Mekla.
I have a suggestion for the previous presenter, Dr. Indra Priyadarshini.
Yeah, Dr. Parthiban, continue.
Yeah, ma'am. Actually, regarding this spindle cell tumor with this myxoid thing and this ALK positivity, the WHO gives an entity, recent entity in the latest classification, the superficial ALK rearranged myxoid spindle cell neoplasm. Morphologically and immunohistochemically, it fits in with that diagnosis, ma'am, because it also has the similar picture with inflammatory cells, but comparatively, the inflammatory cells are less, and it is more cellular and it has got an infiltrative appearance. The
But
spindle
there is
cell,
no
myxoid spindle cell neoplasm.
myxoid areas are not identified.
And the
No, ma'am. When she presented, she said that there was myxoid areas.
But not
Hello,
myxoid.
Parthiban, am I audible? If you could please highlight the immunohistochemistry of the superficial CD34 positive spindle cell neoplasm also. It will be of great benefit to the listeners.
Yes. The superficial ALK rearranged myxoid spindle cell neoplasm usually are positive for ALK1, as well as apart from that, some cases are positive for CD34 and S100. And it is diffusely positive in nearly to 60 to 80% of cases. Whereas the other markers are negative, like SOX10, SMA, CK, and other markers are negative. And sequencing is required for such cases.
Yeah, that's very correct. And the catch here is the simultaneous or the co-positivity for both CD34 and S100, which generally does
because
not.
The rearrangement pattern is superficial.
It is
Hello,
not just
ma'am.
superficial one, it's an infiltrating.
Yes, please go ahead, Dr. Parthiban. Your voice is breaking.
Oh, sorry. So the next generation sequencing is ideal for the specific ALK fusions, ma'am.
Yeah. So for suspicion, I think the markers which we should concentrate on by IHC, CD34 and S100 together will be positive. And on morphology, it has been described, if I'm right, please correct me if I'm wrong. Morphology, the books or the literature says that there will be a lot of pleomorphism, though it is a benign tumor.
Yes.
These are the two things which should make you suspect of such a tumor. And then after narrowing down to the... Hello, can you all mute your mics?
Dr. Parthiban, S100 was done. Dr. Parthiban, S100 was done here and S100 was negative for this.
S100 was negative. Okay, ma'am. Generally, S100 is positive in the superficial mesenchymal spindle cell tumors with ALK rearrangement panel.
Yeah, correct.
And myxoid areas are not there.
And these kind of tumors are more common in the anal region. Yes, Dr. Parthiban?
Yes, ma'am. They can be seen in the extremities and they are common in the superficial dermis.
Now, if S100 is negative, then how do we go about?
CD34, ma'am. Was a CD34 done for this case?
Has not been done. Maybe we'll do CD34 and we'll see.
Yeah, because SFTO the differential diagnosis as well. So CD34 you have to anyway do, I think, Dr. Stats it's soon CD34 and then the take home message is that these are all the things which we have to think of when there is a myxoid spindle cell tumor in the superficial soft tissue. So that's
okay, madam. Okay, that's a nice point to highlight, Dr. Parthiban. Thank you so much.
Thank you, ma'am.
Myxoid spindle cell neoplasm. Thank you, ma'am. Okay, then can we go on to the, if there are no more questions, can we go on to the next presenter, Dr. Muthulakshmi from MMC.
Yes, ma'am. Am I audible, ma'am?
Yeah, you're audible. Please share your screen.
Okay.
Yeah, Muthulakshmi, your screen, please share your screen.
Yes, ma'am.
And Dr. Muthulakshmi, we are waiting.
Yes, ma'am. Yes, ma'am. I'm sorry.
Yours will be the final case of today.
Ma'am, I'm yet to present, ma'am.
Oh, yeah. Dr. Asma, I forgot. Yes. If Muthulakshmi is having a little issues, Asma, you can present. Then maybe she'll take some time and she'll present next.
Okay, ma'am. Shall I share the screen?
Yeah,
Is it
please,
okay?
please share and please continue.
Ma'am, is it visible, ma'am? The screen?
Visible, Dr. Asma, and you're audible. You can continue. Muthulakshmi, please get ready for the next presentation.
Okay, ma'am. I'll finish it, ma'am. Okay, sure.
Yeah.
Okay. Good afternoon, everyone. So today I'm presenting a case which came to our center. It was a 12-year-old male child. He had undergone LDLT in 2020 elsewhere, was on immunosuppressants and steroids in the past, presented with abdominal pain at our center, and the PET CT was the imaging study which was performed here, and he revealed the PET CT findings are revealed circumferential colonic wall thickening with enhancement involving the transverse colon 3 centimeter approximately, and the mild diffuse wall thickening of the descending
Dr.
colon
Asma,
sigma.
excuse me, Dr. Asma, your
Yes,
slide.
ma'am.
You have to start your presentation. It's just in the first slide.
Is it okay, ma'am?
No, it's
softer.
Pant softer.
Material.
You have to start your presentation when it's just the first slide which is visible. Yeah, the clinical history is visible now. You come.
Okay,
You can
ma'am.
use
Is it
the
okay?
full screen mode. Full screen mode.
Okay, ma'am. Okay. Now, ma'am, is it okay?
No, okay, I'm just waiting.
I'll share it again, ma'am.
Yeah, please.
It says share screen, and
so far we are not able to see. Let's see. Okay, Dr. Asma, you can continue if you're having issues. Yes. Your clinical history is visible. Slideshow. You can resume your slideshow, but it's not in the slideshow mode.
Okay.
But you can continue. We'll see. Yeah.
Okay, ma'am. Okay, ma'am. I'll try to get back.
You can see your image. That's your third or fourth slide. Your fourth slide.
Okay, ma'am. Okay. So, is it all visible now, ma'am?
Yeah, it's visible. Please.
Yeah. So he had circumferential colonic wall thickening in the transverse colon, approximately 3 centimeter, with minimal thickening of the descending colon, sigmoid colon, as well as the rectum. Subtotal colectomy was performed at our center, and on gross there were multiple perforation which ranged from 1 centimeter to 2.5 centimeter throughout the colonic and the ileal segment. So these are the images, the colonic segment showing a transmural infiltrate It's a very busy slide, as we can all see, showing a dense infiltrate in the submucosa and throughout the colonic image. Here also we can see that there is a dense infiltrate which is occupying the submucosa and the mucosal lining. Similar view showing the dense infiltrate. I'll go into the details of the infiltrate. Just wanting to show you the pattern. Entire slide, all the sections that were taken showed diffuse infiltration by.
Dr. Asma, your slide is, it's just there in the fourth slide. It's not moving.
Hyper view is not coming.
The slideshow mode illa madam, but at least it just stands with the fourth slide. Yeah.
Now, ma'am, now it's moving for me. Okay.
Now also it's the same. Not moving.
It's not visible, ma'am.
It's
visible only, but it is stagnant with only one slide. It's not moving when you are
It's just stop with the fourth slide, Asma.
Okay, ma'am. Okay. Here I am also facing some issue, I think. Network or
the colonic mucosa and the neoplasm.
What is the age of the patient, Valer?
12-year-old child, ma'am. 12-year-old.
Okay.
Ma'am, now is it visible? Otherwise, I'll stop the screen.
Yeah.
1 second.
Yeah.
Ma'am, maybe she can start Muthu Lakshmi. I'll try some other connection maybe. Okay. Is it a technical glitch or not? I'm not sure.
Okay, Dr. Asma. If Dr. Muthulakshmi is ready, you can share your screen, Dr. Muthulakshmi, please.
Okay, ma'am. Okay, ma'am.
Yeah. Muthulakshmi, you can present on somebody else's screen. Your friends over there. Why don't you try, please? Yeah, when we can't, you're not able to see your.
Yes, ma'am. Actually, Gauri ma'am is trying to share from her mobile. She's not able to because she's not host in this, ma'am. Can you please add her, ma'am? Muthu. Under the name Muthu, can you please make her co-host, ma'am? Yes, ma'am.
You can send it to Valer, I think.
Dr. Muthulakshmi,
Yes,
Dr.
ma'am.
has
Send it to Valer.
Please. Hello?
Ma'am, yes, ma'am. Connecting, ma'am.
Yeah. Yes.
Yeah, Dr. Muthulakshmi.
அத முன்னாடியே கொஞ்சம் அனுப்பிட சொல்லி வளர் போடுங்க.
எஸ் மேம். யூசுவலா ஒன்னும் இஷ்யூஸ் இருக்காது. ஏன் தெரியல
இந்த தடவை ஒருத்தர் கூட போடல. அப்புறம் கடைசியா பத்மா இது இந்த முத்துலட்சுமி இது டே பிஃபோர் எஸ்டர்டே வந்தது.
Next time we'll ensure that they post it, ma'am. Yes, ma'am. Sorry for that. Thank you, ma'am.
I have to go through the slide and read.
கண்டிப்பா மேடம். நெக்ஸ்ட் டைம்ல இருந்து முன்னாடியே 1 week குள்ள போஸ்ட் பண்ணிட சொல்லலாம் மேடம். Sorry for that.
No, not. இல்ல ப்ராப்ளம் ஸ்லைட் வரப்போது டிஸ்கஷன் நமக்கு இது கொஞ்சம் ஹைலைட் ஆகுது இல்ல.
Ma'am, is the screen visible now, ma'am?
Yes.
Yes, ma'am. Continue, ma'am.
Okay, ma'am. Good afternoon to one and all. I'll be presenting the case for city pathologist meet now. So I have made a title as a masquerader for this case. So this is about a 44-year-old female who presented with complaints of abdominal pain for the past 1 month and then she presented with sudden onset of massive hemoperitoneum, for which emergency splenectomy was done and specimen was sent for biopsy. The imaging details were the CCT abdomen was done for this patient, and it revealed a well-defined lobulated lesion in the GE junction abutting the cardia, and clinically they suspected query metastatic GIST or query lymphoma. But since the lesion was adhered to the pericardium, they were not able to take biopsy from the GE junction growth. And there are multiple metastatic lesions in liver and spleen with massive splenomegaly, and the DD considered was lymphoma. And apart from that, there are also lytic metastatic lesions in D10, D12, and L5 vertebral body. Peripheral smear was also done for this patient, and it revealed dimorphic anemia and leukopenia. Liver biopsy was sent 2 times for the patient, and it revealed no evidence of ATP or malignancy. And then the patient presented with massive hemoperitoneum, and so was proceeded with emergency splenectomy. So this is a gross specimen. Grossly, where multiple nodular lesions were made out on the external surface. On cut surface, first a solitary space occupying lesion was seen, and on parallel sections, multiple nodular gray-white lesions were made out. On histopathological examination, there was extensive areas of hemorrhage, and there were also anastomosing vascular channels and solid sheets of neoplasms that were seen. Under low power, there's vascular channels as well as solid sheets were lined by atypical round to oval cells, and it showed scan to moderate cytoplasm and pleomorphic vesicular nuclei with coarse chromatin. And with this microscopic picture, vascular neoplasm was considered, and angiosarcoma was considered, and proceeded with the IHC markers. Ka67 and ERG was added. Ka67 showed 50% positivity, and ERG showed diffuse nuclear positivity in the tumor cells. And based on this histomorphology and immunoprofile, the possibility of angiosarcoma was considered. So this is a case of splenic angiosarcoma. Splenic angiosarcoma is most commonly seen in elderly patients, but can be seen in any age group. There is no particular sex predilection for angiosarcoma. Usually angiosarcoma is disseminated at presentation. Splenic angiosarcoma is disseminated at presentation. The clinical features will be the patient may present with fatigue, fever, weight loss, abdominal pain, and cytopenias, and they may also present with the splenic rupture and massive hemoperitoneum. And in this case, the patient had features of abdominal pain, cytopenias, and splenic rupture. And the major drawback of this is it is difficult to ascertain the primary site, whether it is a primary angiosarcoma or whether it is an extrasplenic manifestation. It is not associated with the vinyl chloride or thorotrast exposure, and this has got a very poor prognosis with hematogenous mets to liver and lung. And grossly, the marked splenomegaly will be present, and it can either be present as single or multiple hemorrhaging and necrotic masses, or diffuse infiltration can be seen. And histopathological in picture, the pattern can be either irregular anastomosing vascular channels, or that can be solid masses occluding the vascular spaces. The neoplastic cells can either be flat, spindle-shaped, polygonal, epithelial, or can be poorly differentiated. The atypia may vary from mild atypia to severe atypia in the splenic angiosarcoma. And IHC markers, the positive markers will be for endothelial cell markers like CD31, CD34, ERG, factor 8, and the vascular endothelial growth factor. And D240, if it is positive, then the lymphangiosarcoma should be considered. And this is the vascular lesions that are commonly seen in the spleen. It can either be non-neoplastic, benign, or malignancy. Under benign neoplasms, the most common neoplasm that will be seen in the spleen is the hemangioma. And in malignancy, it can either be Kaposi sarcoma or angiosarcoma. Primary splenic angiosarcoma is a very rare presentation. Under differential diagnosis, those can be considered hemangioma. In hemangioma, cavernous hemangioma can be considered, but in this atypia will not be present, but the vascular markers will be positive for this. And next is the hemangioendothelioma. In hemangioendothelioma, epithelioid hemangioendothelioma can be considered, but the neoplastic cells can be present as trans nest cords, and it has eosinophilic cytoplasm with intracellular vacuoles in a myxohyaline stroma. Next is the Kaposi sarcoma. The Kaposi sarcoma, this occurs in HIV patients where there will be spindle cells will be predominant, and in this HHV8 will be positive, whereas in angiosarcoma it will be negative. So this case is being presented here for this rarity, and this case was diagnosed mainly based on the clinical presentation, the histopathological features, and the IHC markers that were done. And splenic angiosarcoma has got an extremely poor prognosis. Thank you.
What were the IHC markers done? Of course, the histopathology proves, but wow, the IHC markers were done here.
ERG and Ki67 was done.
You-
ERG
you're-
showed
You
diffusion.
have you saw the picture, ma'am?
Ma'am?
Oh, ERG, okay.
போட்டிருக்காங்க. No.
Okay.
What was the differential diagnosis? Why you thought of a vascular tumor and straight you put the proper marker, isn't it?
Yes, ma'am. Vascular neoplasm, we put the IHC marker.
I thought of a caposiform hemangioendothelioma, more common in retroperitoneum, but age is a very younger age group, it should be. And spindle cell hemangioma, sometimes distal extremities, it can combine with the Kaposi's and the cavernous hemangioma. So, splenic site, we never thought of it. Because splenectomy, why it was done, I was breaking my head. Then the sections were taken from the spleen, this one?
Ma'am? Yes, ma'am. From the...
There was evidence of metastasis, Dr. Muthu?
Ma'am?
Was there any evidence of metastasis? I didn't note the history.
They have given, actually, the patient has G junction growth and it was given as metastasis to spleen and liver in imaging, ma'am. They were suspecting lymphoma in liver and spleen. But
So what happened to that patient? Just wanted to know that. Can you just focus on the history, please, again?
Yes, ma'am.
Yeah, the next slide. Multiple metastatic lesions in the liver and spleen with massive spleen. What happened to the liver?
Liver, 2 times USA biopsy was done, but there was no evidence of any ATP or malignancy, ma'am.
But
what was the lesion? What was the lesion in the liver?
Like multiple nodal lesions were seen in imaging, ma'am.
That's what I want to know. What was the nodule? Now, you could make what's the diagnosis of the nodule?
Maybe they missed the site, I think.
I just wanted to evaluate the patient as a whole.
It was not a representative biopsy of liver.
That's what.
Ma'am, upon the G junction, madam, welcome, ma'am, Padma, ma'am.
Yeah. G junction, we did not receive only this, and it was not representative liver.
Okay, ma'am. On the vertebral body, also.
We didn't get all that.
No, PET CT would have given the clear picture. That was enough.
No, we got biopsy of liver and the cell.
Because in Stanley, we had recently a case of angiosarcoma of the liver, madam, and it showed evidence of metastasis to the spine. They had a similar case with metastasis. So that's why I want. Just 2-3 minutes back.
So, way you were questioning, I thought something curious about it.
Dr. Padma, have you got the specimen with you? Dr. Padma, have you got the specimen with you?
Yeah, we have the
specimen is very good, madam. Nalla irukku.
Yeah, very beautiful.
Specimen is very good. The gross specimen.
Yeah.
Beautiful.
Stanley the liver angiosarcoma, it showed evidence of metastasis to the spine, madam. A similar history with light lesions in the spine. So that's why.
Yeah, but we didn't get the
Any positive history in this case? They said no positive exposure to anything. But what about your
No.
liver angiosarcoma, Valar? Any positive history to exposure to?
Yes, madam. The patient was exposure to vinyl chloride was there, madam, in that liver. Yes, ma'am.
Oh, he was working in an industry or something?
Yeah, she was an industrial worker, madam.
Good, good. Very both the
Okay.
cases.
Okay, madam. Thank you, madam. And we are done CD. Okay, madam. Thank you, madam. Thank you so much. Thank you, Padma, ma'am. And thank you, Dr.
Thank you for the
That was a very
opportunity.
nice.
Thank you, ma'am.
Dr. Asma, if you're ready, we can.
Ma'am, am I audible,
Dr.
ma'am?
Asma? Yeah, you're audible.
Ma'am, am I audible? One second.
Yes, Dr. Asma, you're audible. Please, go ahead.
Yes, sharing, ma'am, sharing. Host, sorry, ma'am. I need to be, I think, enabled. I logged in again from a different system, Asma.
Okay. Asma, okay. Just give me a second.
Yes, ma'am. Yes, ma'am. I exited from my laptop. I'm trying from the hospital desktop. So I logged in again.
Dr. Asma, it's done. It's done. You can continue.
Yes, ma'am.
அந்த இவங்கள்ட்ட கூட அனுப்பி
Hello. Ma'am, it's not enabled, ma'am, the screen sharing. For my name, it has to be enabled. Asma,
Just give me
I have raised the hand now.
Yeah, just give me Amma.
Yes, ma'am, I'm able to do it now.
Yeah. Thank you, Dr. Sir.
Ma'am, it's visible now.
Yeah, your screen is visible. Come, proceed.
So this is the case of a 12-year-old male child who had undergone liver transplant in 2020 elsewhere, and he was on immunosuppressants in the past. He presented to us with abdominal pain, and the imaging studies had revealed a circumferential colonic thickening in the transverse colon, approximately 3 centimeter, and there was mild diffuse wall thickening of the descending colon, sigmoid colon, as well as the rectum. A subtotal colectomy was performed at our center, and in gross examination, there were multiple perforations which were ranging from 1 to 2.5 centimeter throughout the colonic as well as the ileal segment. So these are the images, the scanner view and the low power view, where we can see the colonic mucosa and a dense lymphoid infiltrate, which is reaching up to the mucosal surface with evidence of ulceration. Again, the busy slide showing the dense atypical cell infiltrate in the mucosa as well as the submucosa, transmural infiltrate basically reaching up to the mucosal lining, causing ulceration of the overlying epithelium. Again, we can showing you some more images of the dense infiltrate. So this is the high power view showing the monomorphic small lymphoid cells, few having abundant cytoplasm and giving an impression of a plasmacytic differentiation also. And in this again the high power view, we can see the small lymphoid cells all appearing similar in nature, along with few cells showing the plasmacytoid differentiation with abundant cytoplasm. Here we can see some amount of cytoplasm and the nucleus being pushed to the periphery. Plasmacytic differentiation was also noted. This is the lymph node, adjacent lymph node, which was dissected during grossing. So the lymph node also, there is nodal architecture effacement by the similar population. And in the lymph node, we also had evidence of hemophagocytosis. So going to the immunohistochemistry marker, this was the CD3 in the colon as well as in the lymph node. You can see the CD3 is scattered in the paracortex, and there is diffuse effacement of the nodal architecture, and some kind of vague nodule formation also can be noted. CD20, it's in the high power. I'm trying to show you that the CD20 is not diffusely positive. It's a weak CD20 to negative CD20. Few in the background which are nicely positive for CD20. It's in the colonic biopsy. This is the CD45 and this is the CD79 alpha. So CD45 was diffusely positive and CD79 alpha being more positive than the CD20. So that was the striking difference. And Ki67 in the colon as well as in the lymph node, in the low power itself, we can say that the areas are all lit up in the Ki67. It was increased in the colon as well as in the lymph node. Ki67 reaching up to 75 to 80%. This was the MUM1 which was performed, again showing the MUM1 being positive in the colon as well as in the lymph node. So CD138 was also performed in view of the plasmacytic differentiation. It's weak positive and some cells have taken nicely positive for CD138, could be plasma cells here. Now this was kappa and lambda which was performed. We can see that the strikingly kappa predominance in the colon as well as in the lymph node. So I've given the high power picture also, kappa being more predominant than the lambda staining. This was the Eberish. Again, Eberish also lighting up the lymph node as well as the colon. Eber was nicely positive in colon as well as in the lymph node. So summarizing the microscopy as well as the immunohistochemistry, this was a points to remember here. It's a post-transplant case. He is off immunosuppression, presented acutely with abdominal pain and had multiple perforations as well as impending perforation. The colectomy specimen revealing transmural infiltration of the ileum colon and nodal effacement by atypical lymphoid cells, few showing plasmacytoid differentiation. So immunohistochemistry, when we summarize, it was CD45 positive, 20 was down regulated, weak to negative, 79A was the marker which was positive, MUM1 being positive, CD138 was positive in scattered cells, Eberish positive, kappa more than lambda, Ki67 being high, and CD3 being positive in the reactive T cells. 56 was also done, which was negative in the background cell. CD68 highlighted the histiocytes and the CD30 was positive in immunoblast. So this panel was performed as a workup for the post-transplant lymphoproliferative disorder workup. So what we concluded it as was a high-grade B-cell non-Hodgkin lymphoma, CD20 being negative but still qualifies for a B-cell lymphoma because of the CD79A positivity, and it was a non-germinal center type, which is the most common type in the monomorphic B-cell post-transplant lymphoproliferative disorder because of the MUM1 positivity. And Eber-ish driven process, which was EBV driven process, which was highlighted by the Eber-ish positivity. So few points about PTLD. It is always a potentially life-threatening disease, which is more common in the solid organ transplant patient when compared to the bone marrow transplant patient. It is morphologically heterogeneous, as the WHO classifies that it as a polymorphic, monomorphic differentiation may be seen. So this case had a monomorphic atypical lymphoid proliferation in the colonic mucosa as well as in the adjacent lymph node, and they're always at risk of infectious complication in view of the immunosuppression. Majority of the monomorphic PTLD is always B-cell origin. T and NK are also known. That's why we performed the CD56 in this case, and CD138 was just performed to look whether they are plasmacytoma or a plasma cell neoplasm in the background. So that was not there. And CD79 alpha positivity takes us to the diagnosis of a B-cell neoplasm with a high-grade Ki67 index, and EBV association was highlighted very beautifully by the Eberish. So that's all about the case, ma'am. We're presenting this case because in view of the rarity and the way it presented to us, colonic perforation, multiple perforation in the gut. So that's why this case is being presented, ma'am. Thank you. Ma'am, am I audible?
Thank you. Yes.
Nice case, but I have a doubt why that kappa was positive in that.
Ma'am, kappa is restricted, ma'am. Kappa is more positive than the lambda. So it's a clonal population. Kappa has been done to show the clonality.
Okay, but it is not of plasmacytoid origin, isn't it?
No, it's not plasmacytoid origin because 138 was not positive in all the cells. It was MUM1 which told us that it's a non-germinal center, which is the case in monomorphic B-cell PTLDs in a post-transplant setup, ma'am. So CD20 downregulation is also seen in PTLDs when they are on immunosuppression. That's why we have presented this case. It's a B-cell lymphoma, non-germinal center type. The aid to diagnosis was given by 79 alpha instead of CD20.
Okay, thank you.
20 is there, but it's downregulated.
Yeah, very
Yes,
nice.
ma'am.
And the moral, of course, of the story is that don't stop with only one IHC marker positivity.
Yes,
and
ma'am.
like you will be misleaded. Because
Yes, ma'am.
CD20, if it is negative, of course, you have to go ahead with other B-cell markers, also lineage defining markers.
Yes,
like
ma'am. That was the point, ma'am.
like
Actually,
how we
I was more in favor of plasmacytoid. I was thinking of plasmacytoma from the beginning. So I did CD138. Mum1 actually came positive. But then after doing 79 alpha, realized that it was a B cell from the beginning, just with the downregulation of CD20. And 20, if we retrospectively look again,
Okay.
it is weak positive. It's not that all the cells are negative in the background. Some CD20 positivity is still there. Downregulation is there.
Yeah. So what about PAX5, no? Like in case
PAX5, ma'am, we had
CD20
not,
is
we had
negative. We have the habit in our institution.
Yes,
to go
ma'am.
with the PAX5.
Yes, ma'am.
Hello. Yeah. No,
Had
in
not
case
done
we
in this
happen to
case.
have a CD20 negative.
Yes, ma'am.
In progress.
Please go ahead. Yeah, that was my doubt.
No, ma'am, actually we had exhausted the IHC panel. So we could not do the PAX5. Only with 79 alpha and the other markers we concluded it.
Yeah,
Okay.
because they say, like in case rituximab was administered to the patient, the person.
Yes, ma'am. That was the query from the clinician also. So CD20 targeted antibody, would it help or not is the query. So Chandra ma'am, if PAX5 comes positive, do they still proceed with rituximab?
Endorse is the same. Hello.
Hello, ma'am. Ma'am, am I audible?
Yeah, you are, but yeah, tell me.
Ma'am, if PAX5 comes positive in these cases, do these candidates still deserve a trial with rituximab is what I was asking.
Yeah, the trial, of course, it is for us to go back and refer, but in our institute, they administer rituximab only if there is CD20 positivity.
20 positivity. Yes, ma'am. Yes, ma'am. Yes, ma'am. Okay, ma'am. Thank you.
Thank you, Dr. Asma.
Thank you, ma'am.
So, any other inputs? So, Dr. Krishna Kumar was supposed to, and he's just caught up with some work, and so that comes to the end of the presentation. So we have, so this is the beginning. The 2024 has had a good and beautiful start. We have had a host of nice cases, and we have finished on. So we started with Ailviri Madam, and so we have had more of hematology cases like adult T-cell HTLV. We have lot.
Only one more doubt, if you will permit me, I will ask now that Asma is here and he's a hematolymphoid person. And you also said that we finished the hematology session. So am I permitted to please ask?
Please continue.
Asma.
Yes, ma'am.
No, I don't want to. Just two questions for us, for a discussion with Asma so that we also benefit and so do the postgraduates who are attending here. So, Asma, what is your, according to
yes, ma'am,
2022 update, the low grade and high grade differentiation is not based on Ki-67. Is my interpretation correct?
Ma'am, but for follicular lymphoma, we still go with that Ki-67 index, no, ma'am? Less than 25%.
Follicular lymphoma, the grading has been done away with by the current WHO, whereas ICC still in.
Yes, ma'am. Yes, ma'am.
So grading is actually based on the number of centroblasts in the slide, like what you count on histopathology. And Ki-67, I don't think it forms a part and parcel of the grading of WHO follicular lymphoma, because Ki-67 can be high even if the number of centroblasts are less than number per 10 hyperfield. But the grading is actually based on centroblast number only and not on Ki-67. So in spite of the less centroblast number, Ki-67 happens to be higher. You make a note in the, all that is old WHO, not in the current WHO. So the old WHO, you grade depending on the number of centroblasts per hyperfield or per 10 hyperfield. And in spite of the less number of centroblasts, you have a high Ki-67. You make a note in the report, final report saying that it is grade 1, but still the Ki67 is
High
much higher
case.
than what is expected for grade 1. Is how
Yes, ma'am.
the the previous WHO went. But now the WHO 2022, my understanding of that and whatever little I remember is that there is no grading, isn't it? You just put it as classical follicular lymphoma. That's all. So they don't ask us to grade it into 1, 2, 3A because everything is one and the same. And the trials after the last WHO published its presentation, whatever therapeutic trials were undertaken demonstrated that there is no difference between grade 1, 2, and 3A with regards to the therapy. So that is how they have eliminated the grading of lymphomas in the current WHO 2022 is my understanding.
Yes, ma'am.
So that's one thing. And what I'm trying to ask you about is
Why
the DLBCL.
Chandra, the IHC marker tab, no? They would not have referred the recent one. They are forming our follicular thing is graded as 2.
No, ma'am, we have to follow. Probably it has not come out as a hard copy, and that is why your people, whoever reported your slide, did not follow that. But this is what we are supposed to follow henceforth, and it has come out as a soft copy. So probably we'll have to wait for all of us to kind of adapt to these new terminologies and start following it.
One and grading may not be a matter one, I think. The behavior and diagnosis, I think that be taken care of.
Yes,
that is why when you go through, it was not comes under the aggressive types. So
no, it doesn't, ma'am.
Like that.
Yes. So, Asma, the second question is DLBCL, yeah.
Yes, ma'am.
Large, B-cell lymphomas, diffuse B-cell lymphomas. We used to grade them into low grade and high grade. No, like initially, if it is less than 30% or 40%, people used to call it as that has also been done away with by the current WHO, is my understanding. I just wanted to know from you, is that right or wrong, or is there any other thing which we have to concentrate on?
That criteria as such is not mentioned in the new that updated one. So that I think it's the morphology and the markers that we are seeing positivity, and the CD10 BCL, the germinal center and the activated B cell marker we can do along with BCL2, which is the one which can implicate in the fish also.
Okay.
So Ki67 we are still doing, but the criteria as such is not mentioned. That cutoff I have not seen.
Yeah, they have
I can get back to you. I can refer and get back to you.
Please. Yeah, you're more than welcome to. Yes.
Yes.
You can put it up in the CityPath group itself so that all of us would benefit. Thanks, Valar. Thanks for the time.
I'm not there in the group. I'm not
really?
there.
Valar, put an application to Dr. Valar. She will immediately put you in.
No, it's actually saturated, I think, number of participants.
No, we will say, Valar doesn't say no to anybody. She has another group into which she can all put you in.
Oh, okay, ma'am. Okay, ma'am. Sure, ma'am. Sure.
One more thing, Chandra.
Yes, ma'am. Hello, ma'am.
Chandra,
previously, we are not including the PGs, no?
No. Oh, yeah, that's right. No, but presenters are PGs, ma'am.
Suppose if it is not people are not there, then the PGs come. Otherwise, it's usually the consultants who present. Consultants and the APs.
No. I don't have anything against that thing. I welcome. The PGs to be in the. I thought them and suddenly the good only. Good. They will do more workups.
Ma'am, am I audible?
Yeah, கேக்குது. இல்ல ரொம்ப நல்லது.
Signal is not very clear. But yes, you are audible, Bala.
PGs வந்தா நல்லதுதான். PGs, if they are PGs there, it is good only. Chandra. Hello.
Yes, ma'am.
PGs வர்றது நல்லதுதான்.
DLBCL just wanted to know this.
Well, what is the question? Your voice is breaking.
Madam, DLBCL பத்தி DLBCL பத்தி சொன்னீங்க. Just wanted to know.
As to what? DLBCL பத்தி? What is it that you're asking?
And the DLBCL pati you mentioned, just wanted to know what was that clarification?
No. That is, no. Like even today, not only initially, even today, the clinicians, we are not supposed to call them as clinicians. The treating physicians, they ask us, like, did you do the KA67? Based on the KA67, is it low grade or high grade? Is the question which is constantly being posed. It was in practice till the last WHO was in existence to grade a diffuse B-cell lymphoma into a low grade and high grade, depending on the percentage of KA67. But in the current WHO 2022, that cutoff of KA67 is not mentioned anymore to differentiate between a low grade B-cell lymphoma and a high grade diffuse B-cell lymphoma. So that was what I was trying to ask.
High grade B-cell lymphoma.
So how do they differentiate now?
She was answering, like based on the fish, you have to put it up for fish. If the morphology is looking like a high-grade B-cell lymphoma, you have to do a fish as well. Confirm the presence of those two translocations. Double hit and all those things are there, So triple hit has been removed. Double hit, triple hit is based on the presence of c-MYC, BCL2 and BCL6 gene rearrangements. So, 3 irundhuchuna triple hit, 2 mattum irundhuchuna double hit was the proposal in the last WHO. Now the triple hit has been completely removed. Only double hit is in existence. So based on the presence of c-MYC and BCL2 rearrangements, if both of them are present, it is called as a double hit lymphoma, which is again a high grade lymphoma. So the criteria is a little bit different from what it was earlier on.
It just goes as classified as high grade B-cell lymphoma with MYC and BCL2. BCL6 present or absent will not make any implication.
Make any difference. Absolutely. Yeah.
It's just on the basis of prognosis only, ma'am. Prognosis only.
Yeah. So for that, and the choice of chemotherapeutic agent also, there is some difference is what our medical oncologist says. So they still want us to say if it is a high grade or a low grade B-cell lymphoma, for which these are all the criteria, which Dr. Asma was also mentioning. And I think we have to have a class on that. WHO.
All the centers are able to do the
fish.
We are supposed to. Now it is not the case anymore. Like we have to explain to the patients that the implications are there. Of course, all that the medical oncologists themselves do. Just because we are not doing it is not that the medical oncologists are stopping short with that. They are anyway outsourcing on this and getting the fish test and everything else done. So I think we ourselves will have to join together and put up a memorandum of understanding or whatever. Whatever is available in one center can be used by the rest of the centers. So that way, I think we have to work up something instead of saying that it is not available, because it is available, it is being practiced. The only thing is we have to also get into the understanding that we should be able to suggest and use the facilities available judiciously.
We have to upgrade ourselves with the modern advent.
Yeah. Okay, for that, I think we need to get together as a group, and whoever doesn't have anything has to refer it to the person who has it. One center can develop one facility, and mutually all of us can benefit as a team.
Point taken, madam. Point taken. Yes, madam. Thank you. Thank you for that nice input on follicular lymphoma and diffuse large cell lymphoma. And so that was a good start and end to our first city pathology meet. And I think 7 cases, we had enough time for discussion this time. So 6 to 7 cases will be enough. Like
tell you, we can minimize the cases. We'll have more discussions and previous.
Yes, ma'am.
That is more important for everyone.
And the 1 week before, they will be presenting the cases, madam, as you said. Yes, ma'am. Yes, ma'am. Yes, ma'am. Thank you, ma'am. Thank you. Thank you, Chandra, madam, for your inputs. And thank you, Dr. Sarangan. And thanks. Yes, ma'am. Thanks all the participants and Ariel ma'am and all the senior Raji ma'am and Padma ma'am. Thank you, ma'am. So we meet on the next city pathology meet, the 38th city pathology meet in March. According to all of us.
Dr. Raji madam was on the line, illa?
Ma'am, Raji ma'am nadula vandanga ma'am. Raji ma'am nadula the spleen patti ellam ketittu irundha.
Adan specimen.
Yes, ma'am. So yes, ma'am. Thank you. Yes, ma'am. Thank you so much,
Yes,
ma'am.
well,
Thank you,
well done,
everybody.
Girish.
So, thank
First
you.
start.
Bye, ma'am. Bye. Bye.
Thank you.
Sorry.
Bye.
Thank you, ma'am. Thank you. Ail, ma'am, all thanks to you. Thank you, ma'am. Thanks. Thank you.
Okay, ma.
Okay.